Hey guys, I wanted to talk with you about our next guest here on the Human Being to Wellbeing podcast. She is Dr. Mihaela Garita. She is a pharmadoc that received a Bachelor of Science degree from UC San Diego and her pharma doctorate from USC in LA. She's done a bunch of other studies from a postgraduate standpoint around nutritional medicine and clinical nutrition. We're going to be talking about a topic that is very important for anybody that's on the cardiometabolic spectrum to sit back and listen to, because you're going to want to take some information back to your doctors that could change the way you look at your health. We're going to specifically be talking about common things like the use of antacids and PPIs and H2 blockers if you had stomach issues. We're going to talk about the use of over-the-counter things such as ibuprofen and Tylenol and aspirin. We're then going to dig into various diseases on the chronic and metabolic disease spectrum, like diabetes, like hypertension, like high cholesterol. Many people in the United States, in fact, fully, when we combine all those, almost 70% of the people are somewhere on that spectrum. And you're going to want to hear about some of the medications that are either prescribed or over the counter, what they might be doing to actually make you sicker. So sit back, enjoy. Bring a notepad with you, because you're going to want to bring some notes to your doctor and ask them about some of the medications you're on. And I'm hoping that you're going to question some of the things that you think are safe and effective to use over the counter.
Close my eyes, I need to see again.
Welcome to the Human Being to Wellbeing show with Dr. Bernard J. Fragomeni. I'm here to help you learn how to turn your haphazard lifestyle into an on-purpose health style and to permanently transform your life from just a human being kind of bumping along without any real plan to somebody that has a plan and is now learning all things necessary to permanently live as what we call a well-being. Let's get started with today's topic.
Welcome to the Human Being to Wellbeing podcast. Today, as I mentioned in the introduction, we have Dr. Mihaela Garita. She's a pharmadoc, and we're going to be talking about some things that most of you folks should be very concerned about. So if you're somewhere on the cardiometabolic spectrum, meaning you've either gained some weight, you've either been put on a med by your doctor, or using some sort of over-counter remedies to try to help out with cholesterol or any sort of heart disease or issue, hypertension, et cetera, you're going to want to listen in, because we're going to talk about her story. We're going to talk about what she's seen for years with folks that she's worked with in helping them get healthier. And we're going to be specifically talking about some of the nutrient deficiencies and some of the blockers that can be put on various metabolic pathways when you're using either prescription medications that are actually onboarded by your physician to help you if you're somewhere on this cardiometabolic spectrum, and or you're using some of the over-counter things, whether it's Tylenol, ibuprofen, any of the antacids or PPIs. We'll hit on that a little bit, even though that's not folks on the cardiometabolic spectrum. But I want to welcome in Dr. Mihaela Garita, who hails out of Surprise, Arizona, which, for you folks that don't know that, that's outside of Phoenix, Arizona. She's got two boys, if I'm remembering correctly now. They're probably about 9 and 11. Mihaela.
Yeah.
And what I want to do is just up front is, Dr. Garita, have you talk a little bit about your education. This is it's a little bit newer for people to have a pharma doc. And traditionally, when you and I were younger, you were a pharmacist, you weren't a pharma doc, and there's been more education that's been put towards that. So let's have you first maybe just talk a little bit about your education, and then I'd like to talk a little bit about your health journey and some of the things that you've been through.
Sure. Yes, so I have been trained traditionally as a pharmacist. I went to USC, University of Southern California in Los Angeles. I graduated about 20 years ago with a doctorate degree in pharmacy. Most of my career was actually either hospital pharmacy, which is considered clinical pharmacy. Those are the pharmacists in the hospital that are kind of, nobody ever sees them other than the nurses and the doctors.
Yeah.
But we are the ones that double check all the orders, making sure there are no interactions, the medication is appropriate for the disease state, the there's no contraindications, dose is appropriate. So, and then if there's ever any kind of issue, we do call the doctor, and we help the doctor clarify. So sometimes the doctors do have their own reasoning and we are just not aware of that, but other times it's a true error. So basically the clinical pharmacists are the ones that keep patients safe in the hospital. And then about half of my career, I worked as a research pharmacist, which basically meant that I was dispensing investigational drugs that have not been on the market, and they were part of clinical trials. And at the end of those clinical trials, some of those drugs actually came to the market. So I became very well accustomed to the laws and regulations surrounding this aspect of bringing drugs to the market. So that's kind of like in a nutshell. And then later on, when I decided to shift my focus into functional medicine, then I actually went to the University of Functional Medicine. What is it? Functional Medicine University. And that's where you went as well. So we have that in common. And then I went to the Institute of Nutritional Endocrinology, where I went deep into, I learned how to use foods and vitamins and nutrients to balance our hormones. And by that, it's not just the sex hormones, it's pretty much everything. Like insulin is a hormone. So if you have diabetes, you have a hormone problem, and so on and so forth. So
yeah. So you really shifted, though you started like a lot of folks that get attracted to functional medicine and really trying to get to the root cause of things. For the folks listening that aren't really familiar, that the practicing that many practitioners are getting into of functional medicine is really trying to get to the root cause of what a chronic disease or condition is that somebody might be experiencing for a long time. And instead of trying to, in the naturopathic world, we talk about ameliorating things and trying to mask symptoms as opposed to getting to what actually might be causing things. And what we do find, kind of interesting enough of what you're saying, is gut health and hormone health are at the root cause. In fact, Dr. Pam Smith, who's the head of the Educational Forum for the American Academy of Anti-Aging and Metabolic Medicine, where I'm a senior fellow, she talks about that all the time. She's like, it's either the gut or it's hormones or it's both, and they can be very much tied together intrinsically. So you started to see that from a traditional education standpoint, like a lot of us, that wasn't quite cutting it. You were seeing the prescribing of drugs that maybe were starting to cause some issues with people, whether it was side effects or actual nutrient deficiencies that we'll talk about, became more interesting to you. And it was partly because of your personal story, right? With what you both experienced when you were younger, as well as what you started to experience when you were a little older. So can you maybe give people an idea of your story from a health journey standpoint? Because I think it's very important, because a lot of us that get into this side of the business do it from a personal, whether it's yourself or someone in your family. And I'd love to have, I think people would be very interested in hearing that.
Yeah, so I actually grew up in a very polluted city with heavy metal industry. And I was only about, I don't know, a few hundred kilometers from Chernobyl when that happened, when that explosion happened. So I've been exposed to a lot of heavy metals throughout my life. And then all my life I kind of felt bloated, but I had no idea that that's what that was. I just knew that I was not comfortable. I wasn't comfortable to go outside and run like all the normal children. And then, fast forward about 30, 40 years, I started feeling super weak. I couldn't quite tell what that was. I had a lot of pain. It felt like dental pain, but I went to 3 dentists and they were like, that it's not dental, you're crazy, it's not it. So I'm like, okay. And during that period of time, I was taking a lot of Tylenol, and I knew the side effects of Tylenol, and I knew that it could potentially injure your liver. But I was thinking, well, first of all, I'm in pain. Second, so what else do I have? What choice do I have? Second of all, being a pharmacist, I knew what the maximum dose was. I knew the safe interval to take the medication. So I respected all that. I did not go overboard. I didn't take more than 4 grams. I didn't take it more than 4 to 6 hours. So I thought to myself, okay, I should be safe, right? But I think in the process, I injured my liver quite extensively, because about 7 years ago, I became so ill that I couldn't even stand up. At that time I had a 2-year-old and a 3-year-old, and I was so sad because I waited all these years to become a mom, and now I couldn't take care of my kids. And there were days when I would call my mom to come over to babysit, because I felt like it felt as if I was gonna faint or something. And I thought, like, my kids don't even know how to call 911 if something happens. And I was just home alone with them. And I would go to the doctors, and they would look at my labs, and they would say, well, everything is within normal limits. There's nothing wrong with you. But if you want, we'll give you an anti-anxiety medication. And I'm like, well, anybody who feels the way I feel, if your doctor who's supposed to know what's wrong with you tells you there's nothing wrong with you, you'll get anxious, because then you're like, okay, what is this, right? So, so I didn't want to go on anti-anxiety medication, and I ended up seeking a functional medicine doctor who basically explained to me the difference between normal limits in a lab, which is funny because as a clinical pharmacist, I spent my days looking at labs and evaluating them, but that's all I knew, normal limits. And then he explained to me what optimal levels are, and how you want to be in the optimal level, because that would mean health for you, as opposed to normal limits, which represents the sick population all around you. So, you're not a man, you don't want to be sick. So why would you look at what's around you, right? You want to know what's good for you. So I took a different approach. I did not take any medications. And then I just changed my diet, my lifestyle, and went on I took a lot of vitamins. I replenished everything that was depleted in my body. And next thing I knew, I was well. I also did a liver detox, which it was so dramatic that one day I couldn't stand up, and the next day I had so much energy that I cleaned the whole house. I baked, I cooked. My husband was like, what did you do to my wife? Where is she? So yeah, taking care of it.
Yeah, that's a great story. For folks listening, what really Dr. Gruita is talking about is the disparate approach of traditional allopathic medicine. And I'm not beating up on my allopathic brethren in cadre that's out there, because many of them practice functional medicine as well. So, but it is the difference between allopathic medicine, where there's maybe a pill for an ill. And again, you're mainly treating symptoms, not the root cause of a disease state, as opposed to a functional medicine approach where we're just the opposite. We're looking to find out what actually might be causing this. And for people that have suffered with either migraines or lack of energy, or their gut health seems off, where they don't have consistent bowel movements, or they have urgency to go to the bathroom, their mood is dysregulated, their hormones seem dysregulated, their sleep is dysregulated. When I teach coaches, we teach them, we try to break lifestyle medicine down to really 2 buckets. Is how are you managing your mindset? And it's not just, having a good attitude and kind of toughing it out. It's, how do you manage your mindset? Like, how do you handle stress? Are you sleeping well? Do you need to self-medicate with either alcohol or drugs? Are you binge eating certain types of foods? These are things that we very typically see. That to me, when I talk about clinical nutrition, I break it down to mindset. The other half is what you were exposed to. It's your environment, but it's not just your environment of that you happen to be, downstream from Chernobyl when you were young. It's the people you hang around with. It's the food you eat. It's seeing, getting the proper testing done to not just get your labs back to this normative range, but get them to an optimal range. And that's really where people that are seeking better health need to be speaking with their physicians about, because when you see your test results, typically that you get drawn at your primary care physician, they're comparing you to a very sick population. 70 some odd percent of the people could be plotted somewhere on this cardiometabolic spectrum, as an example, that I talked about earlier on. And you're comparing yourself to the sickest people, not the healthiest people. And, to think it's okay to be on 4 or 5 medications by the time you're 50, it might be normal, but it's not okay. And that's not the way to have optimal longevity and health, so you can be with your children and grandchildren and carry that wisdom forward from a generational standpoint that we need so much in society now. And that's what we're kind of all about when we talk about a functional medicine approach versus a traditional approach that Dr. Gruita was talking about. So you were sick, you got better. You predominantly did it through, like I put it in the bucket of clinical nutrition, as opposed to clinical pharmacology, which is where most people turn to. And if one thing that people get from this is that there's a huge approach in managing your environment, managing what you eat and what you put in your body. And when we talk about nutrition, we're not just talking about food. We're talking about all the different metabolic pathways in someone's body. Because there's some folks I talk to, and I'm sure you get this, Dr. Gruita, when I'm talking to them about that's a nutritional issue, they're like, what are you talking about? This person actually eats a great, they might be thinking they're eating a great diet. Maybe they're eating paleo and eating, 12 pounds of bacon and butter fat or what have you. But let's take something that's even more plant-centric. They might be eating a fairly decent diet, but that's not what we're talking about. We're talking about nutritional deficiencies that can cause harm in various metabolic pathways by having either forward or negative feedback loops to help our bodies actually heal itself. Because at the end of the day, that's really what we're trying to do, is move all these barriers that keep people from being healthy, keep them on medications, in fact, keep them getting prescribed perhaps more medications, and or if they're not even prescribed, people using things over the counter. So when Dr. Gruita is speaking of that, that's what we're talking about. We don't want to go too far into the deep end of the pool and get sidetracked, but let's talk about some specific things that people turn to, because I love that one of the things, and we're going to talk about this at the very tail end, but for those of you that want to look up even as we're talking today, and we're going to be posting some things in the footnotes as well as we speak. But her website is naturopathicpharmacist.com, naturopathic pharmacist.com. One of the things you do that I think is amazing is this medicine cabinet makeover. And what people throw in their medicine cabinet, I like them thinking about their medicine cabinet, honestly, as the refrigerator, in their pantry versus an actual medicine cabinet. But you do this medicine cabinet makeover. We'll talk about that a little bit at the end. But what you started to see as you were more and more concerned and kind of transitioned the health of your own life was there was a huge gap to help other people. And you started looking at different things people were taking, whether they were prescribed or over the counter. So let's start out. Let's talk about antacids or PPIs. So let's talk about some of the ones that people are probably taking. Certainly they used to be prescribed. Now a lot of them are over the counter. Let's talk about them, and then what you see from a nutrient deficiency standpoint and why people should be concerned about those specific deficiencies that might be caused by those things.
Yeah, so it's interesting that we always think we are what we eat, but we are not what we eat, we are what we absorb. And I think there's a huge problem out there where people have what they call acid reflux and or sour stomach. GERD is another name for it. And the common medication to put these people on is either an antacid or a stronger form of an antacid would be an H2 blocker like Pepsid, or a PPI like Prevacid or Protonix or something like that. And these medications, what they are designed to do, they're designed to lower the acidity in the stomach. The problem with that is that our body depends on that acidity. We were created for a reason with that low pH in the stomach, because acid will cleave off all the nutrients from the food that we eat. So even if somebody eats a pristine diet, they eat fruits, vegetables, they only eat organic, grass-fed meat, whatever their definition of good, healthy food is, and they truly are eating healthy and they don't abuse sugar or things like that, they would still potentially be sick if they take these medications, because the nutrients from that amazing food will not make it into the bloodstream and then into the cells where all the biochemistry needs to happen. And one of the prerequisite courses for pharmacy school was biochemistry, and then we studied it again in pharmacy school. And you would think that pharmacists, nurses, doctors, we would be talking about biochemistry all the time, and yet we are not. Like, I don't even think I've used it once as a clinical pharmacist. But now because my mind is, the mind frame is changed, I look at biochemistry all the time, and we do need the amino acids, which would be, if the protein is the sentence, the amino acids would be your letters. So, and only those letters will be absorbed when you eat, right? So if that protein doesn't get chopped up by that acid, you do not absorb protein in the form of amino acids, and you will basically be malnourished. And it's hard to imagine that America is malnourished, because we are all kind of, we are such an obese country, and yet people are walking around being obese and malnourished. So, and that's a dangerous proposition. So when we look at these medications, then the antacids, it's scary because it literally destroys our digestion, and then it will create a population of malnourished people. So, and I don't want to be one of those people, and yet.
No, we don't want anyone to be,
right.
We don't want anyone to be like that. And we certainly know one thing is, you know, a lot of this stuff was prescribed initially, and many of the things that you rambled off are things that people are taking. I mean, I'm amazed when I go, I do this for research because I really don't shop in these stores very often, but I can remember very clearly, it might've been a year and a half ago, and my wife and I live in, you know, kind of the back mountains outside of Park City, Utah, and we took a venture to the big city, to a Costco in Salt Lake City. And I hadn't been in one of those stores, just to be very honest with the audience listening, for probably 7 years. I don't even know. And I was really doing research to find out that if I wanted people to be able to eat plant-centric diets affordably, knowing that a lot of people do shop in those stores, and I'm not putting anyone down that does, I'm not even putting the stores down, even though some people would, but you know, I was just thinking, like, what organic stuff, rice and beans and fruits and vegetables, could people buy at a reduced price? It was literally why I went there. It was a recon trip for my wife and I, just to kind of get an idea. But what I was blown away by was, not far into the store, and I'm sure probably everyone in the country is set up the same way. You walk in behind the cash registers after you come in through the entrance where all the flashy electronic stuff is. And you go to the other side of the end of these registers with these giant shopping carts that people use to fill up. And there are just rows and rows and stacks of, I'll just put them in antacids, but it's stuff that, some of it's stuff that was prescribed not that long ago. And they don't have those things stacked up there if people aren't buying them. Same thing. We're going to talk a minute about like Tylenol and ibuprofen and over-the-counter pain relief stuff that people think is very safe. But the gist of it is, these things were only ever meant to be taken for a very short period of time. And when I meet people that have been on them for years, and I was one of them, by the way, back in the day, I had a lot of those problems when I was much younger. And I just thought it was something that was in my family before my education. I thought it was just something I was going to have to suffer through. But, you know, many people are taking these things for years, and we can get into a whole other story, and perhaps you and I will at some time. But when you take these things for a long period of time, you suppress your stomach's production of acid. You also suppress bile production downstream. So not only are you not breaking down from a macro standpoint, this job that the stomach acid in the stomach's supposed to do, you're messing it all up as it moves downstream in your body. And then you end up causing dysbiosis in the gut and leaky gut syndrome and many other things that can happen, which actually have a negative feedback loop to the stomach to tell it to continue producing less acid, which you think it's counterintuitive for people. But the fact is, it creates many issues. And in fact, with some people, they're continuing the loop of having chronic GERD, if we want to call it that. And then they can end up with Barrett's esophagus and many of these other issues. And all of it really produced because they started taking maybe Tums at first, but then that didn't work well enough because of what I'm talking about. So then they go to the doctor, they get the PPI or the H2 blocker prescribed back when you had to do that. And lo and behold, you end up with people with very, very big problems from a nutrient deficiency standpoint. You saw people in the clinical side that were taking these things for years and years, right? I would assume.
Yeah, and what's interesting is when I ask people if they're on medications, they tell me they're not on any medications. And then when I ask them, so are you taking Ppis? Yes. Or are you taking Protonics? Yes. I'm like, well, that is a medication.
Yeah.
And what's interesting, usually people would think that if something is over the counter, it must be safe, and maybe the dose is smaller, but for PPIs, the dose is the same, whether it's prescription or over the counter, and anybody has access to it. And what's even scarier is that people think they're not on medication. They feel that if something is over the counter, it must be safe, and that's not the case. And if you want, we can move on to aspirin. Well, aspirin, speaking of clinical trials, since that was my cup of tea for so many, many years, aspirin has never been through clinical trials, not one clinical trial, because aspirin existed before FDA existed. And when FDA was formed, they just grandfathered it in as a medication. And so when FDA came, they required clinical trials to look for safety and efficacy and things like that. Well, aspirin had none of that. And I think, based on what I know from clinical trials, aspirin would never make it to the market today if it were to go through clinical trials. And it's certainly not safe. In fact, it's the number 4 reason people end up in emergency room. Yeah, it's number 4. So the number 4 reason people make it to emergency room, and oftentimes these people end up having to be hospitalized because of severe internal bleeding and things like that. Another drug that people think it's safe is ibuprofen, which is the Advil. People, again, take it like it's candy. They're like, oh, I have a headache. It's over the counter. It's got to be safe. Well, it's the number 5 reason people make it to emergency room. And in addition to that, all the NSAIDs have, there are studies that show that the NSAIDs will increase your blood pressure. So you might be in the early 40s and now you need a hypertensive medication, but it could be because you're abusing ibuprofen because you probably have a headache every day. And instead of figuring out why you have a headache every day, now you're on medication number 2, possibly number 3, because more often than not, people who have hypertension end up on about 3 or 4 medications for hypertension. So, and then Tylenol is number 8 on the reason for making it to ER. So as you can tell, not safe. Just because they're over the counter, they are not safe. And I mean, Tylenol can completely destroy your liver. People commit suicide with it.
Yeah.
Truth be told.
Yeah, it's amazing. It's amazing to hear you. I mean, obviously, I know this stuff, but honestly, every time I hear enough of whether it's out loud or in my head talking. So having somebody else kind of go through and rifle through like I hadn't thought for a while about the reasons people end up in the ER, because in our one company we've got we actually one of the guys is an ER doc that works with us, so he's going to be interested to hear that, and maybe we'll talk about him tonight when I speak with him, but. It's funny because when we talk about people on the cardiometabolic spectrum, what's one of the things that many old school cardiologists that were trained tell people to do? They tell them to take an aspirin, or take a baby aspirin. And the fact is that could be exacerbating or causing other problems that you might not realize. And many of the diseases, hypertension, diabetes, either chronic headaches and or migraines, anxiety, depression, are caused by nutrient deficiencies. And that's why we wanted to do this recording for the folks that are listening, is to get a feel for that. Some of the things that you think you're doing that are very harmless are in fact not. And when we are trained in natural medicine, as I am, we're always just thinking of like, if it's anything exogenous going in your body that is not from food, let's just say, or from building blocks of food or amino acids or certain herbs or certain natural medicines that are less harmful, because everything taken in a higher dose or not with the proper things, or if there's contraindications, could be harmful to somebody. Let's be honest about that. But with what Dr. Gruita is speaking to is some of the very things that you either prescribed or taken that you think are very safe, in fact, are probably causing some of the problems that you're now being put on another medication for. And you get into this tailspin where it seems like your health is constantly getting worse, even if you've maybe done a decent job with moving your body and exercising a little bit or eating a little bit better. Being on these meds, what I call legacy meds, when you uncouple them, I have had a lot of patients and folks that we work with, either through our coaches or myself directly, where there does seem to be like the crack is open a little bit on the functional medicine approach and titrating people either down or off of certain medications or deprescribing. Because we send stuff to the doctors and say, this is what you need to be thinking about. This is what you need to be thinking about. This issue that somebody's having is a direct look in the literature. It's a direct side effect of the medication you put them on. And you're scratching your head to put them on another medication to fix something that might be being caused by the medication that you put them on, or somebody else did, maybe 10 years ago. Because once you get on statins or antihypertensives, the next doctor that sees you for the next issue doesn't think that they're, certainly from scope of practice, a lot of times they're not going to remove them off those medications because they feel that that's not their job. That's the other doctor's job to do that. But there does seem to be a little bit more open-mindedness to it now, I at least see. But it certainly needs to start with you folks that are watching this as an education from a patient. You need to be involved in the decisions in your own health. You need to challenge and ask your primary care physician or your specialist, why am I on this? Why do you think I'm having these side effects? And if you're not getting good answers, fire them. Go find another doctor. I know when you had your health issue, you had to go from doctor to doctor to doctor to find the right one finally with that functional medicine practitioner that would help you. So I want that to be sinking into people about that. I think it's very, very important. Let's talk about statins a little bit. That's always an interesting topic to get on. And I know you updated some stuff for a recent lecture you gave on statins. And it's a fascinating topic because it's another legacy drug that people are on and they feel they're never going to get off. Some of it's a misunderstanding even by practitioners on cholesterol. But let's talk about that and maybe name some of the specific medications if people don't know what we mean by statin. And then let's talk about some of the things that are out there in studies to show whether or not they are safe and effective. And then we can talk about some of the nutrient issues that can be caused by long-term use of statins.
Sure. Yeah. So statins are medications like simvastatin, atorvastatin, lovastatin. These are medications that are used for high cholesterol. And the definition of high cholesterol has actually been moving like a moving target in the last few years. So even that is kind of questionable. But the fact that doctors feel comfortable when total cholesterol is 140 and lower, that's kind of scary. And this is why. We do need cholesterol. Basically, all our cells in the body have a membrane, right? Well, the membrane is made out of cholesterol. So cholesterol is not all bad. Cholesterol is not evil. Cholesterol is super important, but it has to be obviously within the right range. But again, the definition of the right range, we don't really know what that is. And then when that cholesterol gets oxidized, that's the cholesterol that's really toxic to our body. The rest of the cholesterol is not. Even the LDL, which people think it's the bad cholesterol, that's not bad. We need it. So that's one part of it. The other thing is we need cholesterol to make our sex hormones. You don't make enough cholesterol, you're not going to have estrogen, progesterone, testosterone. So that's scary both for women and for men. I've heard of men who were on statins who couldn't think anymore because their testosterone level was so low. And testosterone is actually very involved with cognition and all that. So statins are not some innocent, or actually people think of them as savior drugs. And there are studies out there that actually shows the opposite. So there's a study that looked at 65,000 people, 65,000, not 600, not 6,000, 65,000. So because, and when they looked at, they followed these patients over the years, and they saw that although the cholesterol number was good, was exactly where we wanted it to be, according to the American Cardiology Association, the mortality and morbidity. So morbidity means if you're going to be sick or not, and mortality is you die or you don't. Well, none of them actually improved. So then what's the point? Right? So it's just dust in the eye. Looking at good cholesterol numbers means nothing. And in fact, there are a lot of studies that show that there's other things that one should be looking at, which are much better indicator for, dangerous heart disease or early death. So, and not the total cholesterol. But we are so focused on just that cholesterol and just lowering the total cholesterol and the LDL. And I think the statins lower the triglycerides a little bit, but do nothing for the good cholesterol, the HDL, which would keep you safe.
Yeah, I talked, funny, I want to interrupt you for a second, because I spoke with a gal that I know, and she's so proud, and she should be. Her son graduated from medical school, and he's just been finishing his rotation and is now in a residency for cardiology. And she said, everybody should be on statins. Who told you that? She said, my son, he's on statins. All those guys are taking. I said, well, that's what, when people are first in medicals and first come out, they all kind of think that. But one of the things you're kind of beating around that I want to tell people is, I'm sure you do, you probably recommend that people get a a full lipid profile panel or fractionated lipid profile panel, right? That they go back and tell their cardiologist that they want to see that. So for those of you that don't know, like what we're concerned with more than total cholesterol or even HDL and LDL is certain particle sizes that are stickier and smaller types of cholesterols that tend to be more open to oxidation. So we want to look at lipoprotein A as an example, is one of the ones that we want to look at and see what the level is that people have, because what we found is that's the one more prone to stick to arterial walls. That's the one more prone to kind of alert your immune system to oxidize it, which causes an unstable plaque, which can cause an ischemic event, whether it's a heart attack or a stroke. I'm indifferent to. Those are both bad things that we don't want people having, certainly not with any frequency. But the fact is, that's the piece that we're concerned with, and that's largely genetic, how much you have. And they are coming out with some targeted drugs to try to get after that. But there's also a lot that can be done from a clinical nutrition standpoint as well with that. Um, so you typically tell people to get that panel so that they can really see into it. It amazes me still, Dr. Gruita, that I don't know the percentage. I mean, I could probably figure it out or look it up, but it's amazing to me that when I send a patient back to their cardiologist to get that done, either the insurance company fights it a little bit because they're like, you don't need that. Or the cardiologist does because they're saying like, you don't need that. You just need to keep taking the statin, or they want to put them on a different class of drug or something like that. But that's what really needs to be looked into. Let's talk a little bit about when you're taking them from an overall health standpoint. Irony of all ironies to me is the statins. And then I want to come back and talk about the studies a little bit more too. But irony of ironies, for people that are taking these statin drugs that are on somewhere on that cardiometabolic spectrum that I spoke about, there's one thing that it's not one thing, but there's the main thing that it really affects from a cellular standpoint that can actually be more of a risk for people from heart disease standpoint. So you want to talk about the effects on maybe CoQ10 and mitochondrial health a little bit?
Absolutely. So yes, basically the statins will deplete coenzyme Q10. And what is coenzyme Q10? Coenzyme Q10 is absolutely crucial in the energy production cycle, which is the Krebs cycle, which happens in the mitochondria. And if people don't know what the mitochondria is an organelle within the cell. And the more energy that cell needs, so for example, brain cells, heart cells versus red blood cells, there will be way more mitochondria per cell. So for example, a heart cell might have anywhere about 2,000 mitochondria within one cell, where the red blood cell has no mitochondria in it. And muscle might have about 1,000 mitochondria per cell. So it's very telling that the more energy that organ needs to use up to fulfill its functions, the more mitochondria you need. And inside this mitochondria, there's the Krebs cycle, which produces ATP, which is the energy. When we stop making energy, that's when we are dead. And then the more mitochondria dies within a cell, that organ might become ill, and you're going to see chronic disease within that organ. Well, coenzyme Q10 goes then into the ATP, some molecules from the energy production cycle go into the electron transport chain, which is the final production of ATP. And there's 4 steps in that process. Coenzyme Q10 short circuits 2 of them if you don't have it. So you need coenzyme Q10 for 2 of them, and any depletion of that will stop the energy production. So you can see how that can have big consequences in health. Mm-hmm. And even more interestingly, since the heart has so much mitochondria and it depends so much on that ATP production, when coenzyme Q10 gets depleted, people are going to experience what is known as congestive heart failure. Yep. And there are congestive heart failure experts out there who basically, when they get a new patient, they check their coenzyme Q10. And more often than not, that level is low. And when they put the patients on coenzyme Q10, the symptoms kind of improve so much that there's almost no need for the doctor. Yeah, it's not always the case. Depends obviously on other factors, but that's kind of scary. And here we are giving statins for heart health, and now we're causing heart disease with
it's crazy, right? That's why it's crazy to me that happens. And Dr. Mark Houston, who's written a bunch of different books and is a member of the American Academy of Anti-Aging and Metabolic Medicine as well. And he basically says if people are prescribing statins and they're not at least putting on board CoQ10 concurrent with that he considers it malpractice. Whether the boards do or not, it really doesn't matter. But, you feel, so people know, hey, a side effect is going to be, what does a doctor tell somebody when they prescribe a statin, you may, besides fatigue perhaps, but also muscle pain or discomfort.
Yeah.
Well, there's less, if you heard what Dr. Gruita said, there's even less mitochondria in the muscle cells than there are in heart. The heart is a muscle, but there's even more in cardiomyocytes. Same thing in neurons and stuff that makes your brain up. So brain fog's another thing that people talk about. So that's just kind of almost shrugged off, like, well, it's not a problem. Well, actually, that's a symptom. It's a symptom of what the statin's doing in taking a nutrient depletion. And it really, what it does is it doesn't let your cell, because they're constantly producing this ATP. And what I want to tell people is this is a real issue, because there's not that much excess ATP in the cardiomyocytes that power your heart muscle. It's almost, if you want to think about an accounting comparison or a shipping thing that we've all experienced with this, supply chain disruption, think of it this way. There's just barely enough ATP being kept up in a normal, healthy heart to keep up with the energy needs to keep your heart beating. You can say the same thing for firing your neurons, and you already experienced some of the stuff with the muscle pain that you get. That's part of it. And in a way, it's a way for your body to detox that organelle inside the cell and keep it healthy. So you're not just bringing nutrients into the body and moving them and shuffling them around because we're all different biochemical experience, just for no reason. There's a very serious reason with this, and it's to keep you alive. And it's to keep you from having to be prescribed yet another medication to fix a problem that's something you might have already been taking for a while has actually caused and or exacerbated. And I say that as a disclosure, because we're not going to say it's the root cause of everything. But nobody ever died because they didn't have enough statins. It's never happened in the history. That's not a nutrient, so that's never happened. And I feel very safe and comfortable saying that and putting that out in the public forum. I'm not going to. If anybody wants to challenge that, I'll be happy to have a conversation with them. But nobody ever died from a statin deficiency, but people do die every day from nutrient deficiencies. And obviously the topic that we're speaking to, understanding, is that nutrient deficiencies can be caused by some of these things and therefore cause or exacerbate other downline health problems. And the fact is, even more recent studies that you're referring to don't show a reduction in mortality, morbidity. And some studies have even shown that there's a higher level of mortality in patient populations that have been taking statins for a long time. Now, there could be other reasons for that, but part of it, surely if you're hearing what we're talking about with CoQ10 depletion, is probably part and parcel caused. I mean, in essence, we're poisoning our mitochondria, especially in the cells that should be powering the very same thing that we're taking it for to help. And I think that probably ties a nice knot around that. And let's talk about, there's a lot of people on the cardiometabolic spectrum that are diabetic, right? Type 2 diabetic is what we're predominantly talking about versus the people that are primary diabetic. Let's talk about some of those drugs like metformin and some of the other ones. And there's unfortunately, they affect CoQ10 as well, but there's some of the other nutrient deficiencies that they cause. So let's have you kind of talk about that if you can, Dr. Gruita.
Yeah. So metformin is probably the most used drug for diabetes. I would venture to say that probably everybody who is newly diagnosed or has been diagnosed forever, they are on it. And when I was a hospital pharmacist, I could see it. Every single patient was on it, and even patients for which it was actually contraindicated, and it's contraindicated over age 70, while majority of these patients were over 70. So we were still giving it. It's contraindicated if you have renal disease, and it was still given. And, the doctor might be open to change it if the renal dysfunction was quite severe. But if it was just a little bit of renal dysfunction, they would do absolutely nothing about it. And I thought that was crazy, because if a drug company actually bothers to put that contraindication on their package insert, there might be something to it. And so that wasn't happening. And so, yes, metformin also depletes coenzyme Q10. It also depletes vitamin B12, which is also super important to make new ATP, to it has so many functions, and usually the people that have vitamin B12 deficiencies cannot drag themselves through the day. It actually manifests itself as anemia. Oftentimes it's even confused with iron anemia, but it's not iron, it's B12 deficiency. And
well, that's very important to say. So repeat that again, because many clinicians don't get that, and
Right.
they go down a different pathway. So repeat that again, and then talk about what happens a lot of times in a clinical setting.
So the symptoms are almost identical, and hemoglobin and hematocrit, which is what we look at to say when these are low, we are going to say, oh, this is anemia. And oftentimes we think, oh, we need just some iron. Go be a little Popeye, eat some spinach and some steak, you'll be fine. Or in the worst cases, we might even give them supplements, iron supplementation. And the problem is that's not always the case. Oftentimes it's actually B12 deficiency. And there's other labs that will actually clarify that other than the hemoglobin and hematocrit, like the MCV and CHC and all those labs will show us the size of the red blood cells, whether they're small or large. And based on that, we can tease out the actual cause of the anemia. But having said that, again, going back to the root cause, just because we know which type of anemia is, then we would need to always question, well, why do you have B12 deficiency, or why do you have iron deficiency? And oftentimes it is the medications that we are on, and metformin is one of them, to deplete B12. And these people are going to be really tired. Sometimes they develop what's called neuropathy, which is kind of like a tingling in the feet and in the fingers. Sometimes they lose sensation altogether. So that leads to the bad side effects of diabetes, where you might be stepping on, like, let's say, a needle, and you actually get injured, but you do not feel any of that. That then turns into infection. That infection then gets out of control. And what happens? You lose your foot. And or with the fingers, you cannot even close your own buttons on your shirt. And so the quality of life, obviously, is gone, on top of the fact that they're in pain. But when you start losing limbs, that's really not
traumatic. And again, it's another case for people listening here. It's another case of where a medication that's put on board to help a chronic disease / condition that people have, some of it self-inflicted. We know how people end up with type 2 diabetes and go down that pathway. But a symptom that's attributed to the disease is actually either caused or exacerbated by the medication that's put on board for that specific disease. And it's become normative to consider that, well, if you're down the path and you're on metformin, you're type 2 diabetic, you're going to end up with peripheral neuropathy at some point, very likely. But the fact is, it's a nutrient deficiency that's either causing or exacerbating it. And again, just like the story we talked about, with the issues with CoQ10 with statins, here you go. You've got almost a similar type of a discussion with it. And B9 as well, right? B9 is another one that can be depleted as well. So think about what Dr. Gruita has been speaking about, is that if many people that she and I end up speaking with, they could be somewhere on the cardiometabolic spectrum, likely taking a statin, likely on something for type 2 diabetes when they first come to speak with someone like us. And by the way, at some point, because they had digestive issues, they were taking an antacid or an H2 blocker or PPI, and they had less absorption of these nutrients, less movement of these nutrients, blocking of pathways, as we talked about early on. And I hope that it's getting clearer and clearer as we're talking through this for folks that this might be new information for that. Boy, I should maybe talk to my practitioner. And if I don't get the results from my practitioner, maybe I should talk to somebody like Dr. Gruita and potentially think about getting a medicine cabinet makeover, which we're going to talk about right after we talk about antihypertensive medication. So let's move on to that, Dr. Gruita. Let's talk a little bit about, so let's name some of those medications that people are probably on so that they know what we're talking about. And then we can differentiate between, calcium channel blockers, et cetera, and what issues that they kind of exacerbate or maybe even causing.
Yeah, so there's few classes of antihypertensives. There's the beta blockers. Those are things like atenolol, anything that ends in lol.
Mm-hmm.
It's a beta blocker. Then there's the calcium channel blocker like nifedipine, amlodipine. There's ACE inhibitors. There's the ARBs, the angiotensin receptor blockers, and these are like losartan, and I think they always end in, they have the same ending, so it's easier to kind of figure them out. But they are, and then there's the diuretics. Don't forget the diuretics, which are also antihypertensives, and that's how they're being used most of the times. And what happens also, majority of these drugs are packaged by the drug companies together with diuretics. So more often than not, people they might think that they're on one medication, but they're actually on two, or they think they're on three and they might be on four, and something like that. Majority of these antihypertensives will deplete magnesium. And what's ironic about that, as I mentioned, there is a class of antihypertensives called calcium channel blockers. Well, magnesium is a calcium channel blocker. So here we go again, we are giving medication to reduce hypertension, and we deplete magnesium, which is needed to maintain the blood pressure in the body. So now it's a vicious cycle again. Yeah. And what has happened, and in clinical pharmacy, we see that all the time. Basically, the patient gets diagnosed, they get put on the first medication. Most of the times, the first medication is a diuretic. They get put on that. Then, as the hypertension is not controlled, surprise, surprise, then they'll go up on the dose till they reach the maximum dose. Once the maximum dose is reached, the doctor will reach for the second medication, and they'll put them on the second medication. Same thing over and over again till you reach the maximum dose. Then you'll go to the third medication. And in the hospital, at least all the patients that were admitted, probably 90% of them were on 3 or 4 medications. And so if they all deplete magnesium and some of them deplete vitamin B12, what do you think happens to these patients? Some of these medications will deplete coenzyme Q10. So I actually do have a quite interesting story. I had a patient who was put on a beta blocker like atenolol because of palpitations. This client didn't even have hypertension, but that is practice where you put patients on a beta blocker if they have palpitations. So this patient ended up being so tired that had to drink 5 coffees a day. This client in particular is a physician assistant seeing patients. So this person had to go drink a coffee between every patient to be able to even sit there and listen to her own patients. So, needless to say, her life got wrecked. And she goes back to the doctor, and she begs the doctor to change her medication. The doctor puts her on a calcium channel blocker now, and she develops hypertension. So So after 2 antihypertensives, now she develops hypertension. So how do you explain that? And it's very simple. It is going back to the nutrient deficiencies. Well, the beta blockers deplete melatonin, so you don't sleep at night, and they deplete coenzyme Q10, which we just talked about, that you have no energy. And that's what happened to this patient. Then when the doctor switched her to a calcium channel blocker, the calcium channel blocker depletes magnesium and vitamin B12 and coenzyme Q10. So here we go. Now she became hypertensive because most likely the magnesium, and actually depletes the sodium and the potassium and all those, right? They are so important in blood pressure maintenance in our body. So basically what we did, we went back to the stomach, making sure she's absorbing her nutrients. And she went off her medications. I put her on magnesium, coenzyme Q10, melatonin, and she sleeps through the night, and she drinks coffee because she loves it, not because she has to survive her day. So, so this is just such a stunning example of what medications can do, and nobody knows. And the pharmacist will not pick on it either, because in pharmacy school we do not learn this.
No.
Right?
Well, medical school, the doctors don't learn it either, because what we're talking about collectively for people, I like to keep recapping, is when I say nutrition, and I'm talking clinical nutrition to other practitioners and other healthcare professionals, they always hear the food you eat. They do not hear this piece of it. But the fact is, everything we're talking about has to do with nutrient depletions. It's the nutritional profile of a patient that has dramatic effects on the biochemistry and the reactions that we all have continuously, millions and millions and maybe billions going on per millisecond in our bodies, that has genius behind it. But when you stop the way things should be coming in or produced endogenously, and you're adding on a lot of things exogenously, it can have the good thing that they're trying to get something to do. So I don't think it's not done on purpose by the pharma companies, even though we could beat up on them. But the fact is, there's these side effects and byproducts of this very often are worse than what they were trying to treat underlying. And when we can look back, when I talk about clinical nutrition, hopefully that helps people that are hearing me say this. When we talk about gut health, we're talking about everything from your mouth to your anus. So we're talking about everything that has to do with, because it's really inside but outside your body. And if it's not functioning optimally, it disrupts and causes all sorts of things with absorption of nutrients, digestion of nutrients. And it's of extreme importance for people to start to understand this, to be able to better take care of yourself, or select a healthcare provider that can help you better take care of yourself. So you have to look at all these things. And by the way, I bet you your PA that went through this, because there's calcium receptors and neurons in the brain, probably was able to think a little bit more clearly and have a lot more mental acuity in dealing with patients, I would bet. So for all those people, there's these constant symptoms that we hear from people. My gut doesn't seem to be working properly. I have irregular bowel movements. I don't have any energy. I'm not sleeping well. I can't think straight. I have this brain fog thing going on. And I'm talking to some of the people with this long COVID thing, because a lot of it goes back to the genesis of nutrient depletions and stuff, as far as malfunctioning in a dysbiotic lower gut, as well as a malfunctioning digestive system that's not getting you the proper nutrients. And so everything we're talking about has to do with that. Let's talk about, is there anything else you wanted to add on the antihypertensives? Did we get through that all, or did we not? I don't know if we got a little off track there.
So yeah, no, I think that's the gist of it. There will be nutrient deficiency. So what happens quite often, people get diagnosed with hypertension. That seems to be the first thing that goes. And that could be because we drink too much coffee, or we drink energy drinks, or we drink soda with a lot of caffeine, and caffeine will deplete magnesium. So, and these people end up on antihypertensives that will deplete more magnesium, will deplete B12, will deplete coenzyme Q10. Then they become diabetic. After they become diabetic, then they might have also cholesterol issues. And that's one of the things that the ADA, the American Diabetes Association, recommends, to keep cholesterol down if you have diabetes. And so some of these people don't even have high cholesterol, and they will get put on a statin. So
Right.
it's like clockwork. You see that. And when I was working in hospital pharmacy, I was always flabbergasted because pretty much almost every order had 20 to 30 drugs on it.
Yeah.
And I thinking to myself, before I even knew anything about this nutrition and functional medicine, I kept thinking, who ends up on so many medications and why? And that was always going through my head as I was working my job. And now I know. Back then I couldn't answer, but now I know the answer.
Yeah.
That the nutrient deficiencies are what leads to more symptoms, for which you get put on more drugs, which then will have more symptoms caused by more nutrient deficiencies. And that's how you end up on so many drugs. And in clinical trials, speaking about the pharma, sometimes it's hard to anticipate what the side effect will be. And unless you ask a specific question, the clinical trials are not going to look for that. So let's say there's drug A that it's going through clinical trials right now. If the protocol was not written to say, I wonder if this will deplete magnesium, let's check magnesium every month when the patient comes to see their doctor, that does not get done, and there will not be on the package insert, and it's not going to be in the medical literature to talk about later. But sometimes when you look at the side effects, you can still kind of extrapolate from there that certain nutrients must be depleted. So I think one of the, I'm trying to remember which one, but one of the diabetes medications causes congestive heart failure.
Yeah.
Could it be a coenzyme Q10 deficiency? So, I looked through literature, through PubMed, and I searched. There's no such talk about it. But can we use our judgment? Or if a medication causes diarrhea, can we say that they are losing potassium, sodium, chloride, magnesium? Because we know 100% that when you vomit or you have diarrhea, you are going to lose those electrolytes.
Right.
So it's sometimes we just need to think literally.
Yeah, and it's literally why many people that are on these cascading needs for medication end up in the emergency room with something just as simple as that, where they get an IV drip, they get electrolytes put back on board, and lo and behold, they go from looking like they're going to die and are rushed to the emergency room to being completely fine shortly after their, I don't call this proper hydration any more than you would, but properly hydrated, are kind of brought back because simple things like this get brought back into balance. Would you say too, one of the things I wanted to ask you before we move on to talk about medicine cabinet makeover a little bit, would you urge people to ask their doctors to either, maybe you can't use the terminology with them to say, get me some functional medicine labs done, but maybe ask for more nutrient testing to look at some of these things? Do you, and some doctors are going to tell you probably they don't do it or their insurance doesn't cover it, but how important do you think it would be that people insist on that? And is it something you're suggesting in your practice right now?
So I can see how that could be a good thing. I don't recommend it for one reason, and that is the more basic labs that can be done. They're always looking in the serum. Not all the vitamins are actually extracellular, which would mean in the serum. So magnesium, for example, is one of them. Only 1% of magnesium lives in the serum. So when I was a hospital pharmacist, I would always ask the doctor to order that. And now I'm thinking back, I'm like, oh, that was so silly. But that's all I knew. And what happens with magnesium and in the hospital, oftentimes we had to respond to codes. The code, meaning it's code blue, a person is dying, basically. So you run, the whole hospital runs. So if you've seen the movie ER, you kind of know what that is. So you go there, and then the doctor always looks for the pharmacist and says, I want a magnesium drip. And it's not always, it's depending on what the rhythm is, but often you will get that. And pharmacists are also trained to look at the rhythm and anticipate what the doctor will want. And so we would be making the IV magnesium, give it to the nurses, and then shortly after that, the patient will recover. And so where I'm going with that, but yet in the meanwhile, their magnesium level was normal. Well, that's because the serum level is just 1%. Everything else lives inside the cells, so you do not measure that when you just go and you say, okay, because when they do your testing, it's most of the times serum. Lately, you can measure the magnesium inside the red blood cells, and I've seen it more and more often done where the doctors will prescribe red blood cell magnesium. But it's not all the time. Right. So maybe something like that I would ask them to make.
Yeah. So what you would do is maybe instead of telling people to get this is what I was kind of getting at is partially you just answered it. So I wanted people to be able to hear your thought process on it as well, because you and I hadn't ever spoken about that. But there's all sorts of functional medicine labs we can have people do, but they are expensive. A lot of times they're not covered by insurance. And, there is an art to the practice of medicine. It was always supposed to be that way, even the traditional allopathic way of practicing medicine. And there can sometimes be, and this might not sound copacetic to some people to hear this, there can be a little bit of trial and error with it. I mean, in essence, a doctor that's trying to treat your hypertension, let's say, that cycles through different classes of drugs, trying to find the one that finally works for you. That's what they're doing. They're trying to titrate the dose up or down. They're trying to see if one class works better for you versus your somebody else in your family or another patient. So that's practicing the art of medicine. But from a natural medicine standpoint, we can do that too. We're going to say, all right, instead of ordering all these expensive tests, let's just put some on board. Let's put some, in this example, magnesium, by the way, we didn't talk about this when we were talking about magnesium initially. But magnesium is the mother load of it. Like if you don't have enough magnesium on board, there's many things in your body that are not going to be optimized and functional at the level that they're supposed to. So would you recommend people to obviously try to work with somebody that's a professional and educated like yourself, or somebody that understands it in the capacity from a clinical nutrition standpoint? Would you just say, let's try to put some on board and we'll try to get and see what happens with your condition and see if things improve? Is that what you do instead of ordering a bunch of expensive lab tests?
Yeah, so that's one way to look at it, because everybody is magnesium deficient for various reasons, including the quality of the topsoil these days. Yeah. So an apple that we eat today is not the same apple that grandpa ate 100 years ago. So even the vegetables and the fruits we eat, they're not so full of nutrients as we would like them to be, or as they used to be. So yes, I think a magnesium deficiency is pretty prevalent, and I depending on what the symptoms are, yes, I would just go to that, and but then the simple labs like the metabolic panel. And even if you order the red blood cell magnesium, it's not expensive. So we can order those for these patients. And what I oftentimes do, I give them a list to the patients, and I tell them, take it to your doctor, ask them to order these labs, because then the insurance will pay for it. But if I order it, because I'm a pharmacist, the insurance will not pay for it.
Right.
So I work with the patients to try to get the best value for their money. And there's a lot of things that we can extrapolate from these labs, from just the CBCs and the CMP. So that's the first thing I do before I go to functional medicine labs, because the price.
Yeah, no, I agree with that. And that's more, I think early on I started having people go either directly to a lab that I thought that I needed them to do, and they run a bunch of tests, or I sent them back to their doctor with a bunch of extraneous things. And half the time the doctor would say, no, I'm not going to test for them because that they're maybe not traditional, or maybe they're not covered by insurance. And now you can infer a lot of stuff by symptoms, looking at the history, looking at, the typical things like what medications are on that we know maybe have blockers in certain nutritional pathways, and kind of go from there. So on that note, one of the things that we're going to put up at the end is we'll put your website back up, naturopathicpharmacist.com. Two, if you want to, we could include a link to your ebook that you wrote, where we've been talking a lot about a lot of these topics today with Dr. Gruita, and she has an ebook that has some good summaries of some of the things that we've been speaking about, so we can make that available. And then three, through your website, people can contact you directly and set up an appointment to do a medicine cabinet makeover. I've said it about a dozen times since the beginning of the call. What is, in real short, what is a medicine cabinet makeover? What do you do? What could people expect if they engage with you to do that?
Yeah, so basically I approach health by, if they're on a lot of medications, I look for the nutrient deficiencies. I look for nutrient drug interaction. That's not done quite a lot, although there's a little bit of that happening in the allopathic medicine, where you might be told don't drink your grapefruit juice with the statins, but that's kind of like the extent of what I remember. Like with certain drugs, like with the MAOI inhibitors, don't eat your cheese. But that's about it. Where I'm looking for, if you're on vitamin C and you're on this medication, is it safe? So I evaluate that, and the nutrient deficiencies, and the obviously the short-term goal would be to replenish the nutrient deficiencies based on the medication profile. But then ultimately, and it's up to the client if they want to continue to work with me, you need to look for the root cause of your original symptoms. So if you had migraines and you had food sensitivities and you didn't know, and you kept eating them and you kept having migraines, and you take your ibuprofen and now you have hypertension and blah, 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 the thing goes, then, so I kind of go backwards just to see, well, what was the original thing? And even then, it's like, well, but why did you have food sensitivities? Like, why would you have that? Because not everybody that eats chocolate will have a headache, right? So, you dig deep and look for the root cause. And once you fix the root cause, the symptoms downstream will resolve. And so that's my approach to help.
That's awesome. Well, this has been great. I always love talking with you. I feel blessed that I got a chance to meet you now over a year ago, as we were talking recently. And I think you're a great resource for people. I know you and I will be working together in the future with patients and referring folks back and forth. And I hope that folks got a lot out of this talk. I know every time I sit and talk with you or hop on the phone with you, which I think is going to be for a couple of minutes, and we get talking, I learn every time. So I want to thank you for coming and letting me pick your brain on these topics that I think are very important for people to consider.
Pleasure. My pleasure. Thank you.
This has been the Human Being to Well-Being Show with Dr. Bernard J. Fragomeni. Make sure you check us out on all of our social media platforms so you can stay in touch and in tune with everything that we're bringing you around health style, transformation, natural medicine, functional nutrition, nutritional psychology, and the whole gamut that's going to make you live forever as a well-being. Go out and make this day the best day you've ever had, because it's the one that we've got.
Please remember that the topics of discussion contained in today's podcast are for informational purposes only and do not construe any sort of recommendations, changes you should make, or medical advice whatsoever. If you're interested in discovering whether you're a candidate for changing anything from a clinical nutrition standpoint, from an exercise and lifestyle standpoint, please speak with your primary care physician before you take yourself off of any medications or make any changes that may have been mentioned in any of the topics of one of the podcasts. Again, consult with any specialists or any doctors that you're under the care of to see if a change in overall lifestyle, including anything around exercise, medications, diet, makes sense for you as an individual patient. Always go back to your primary care physician and or specialist. Again, nothing contained herein construes medical advice and is only for informational purposes. Go out and make this a great day.